Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Like I said, I think for when we are live together next, I'm going to show you the yellow legal pad of all the ideas of all the episodes that I put together. But as I was planning December and I was planning this kind of year-end wrap up, roundup of all the things that I've learned actually this year. This year seemed
Mhm.
like a big learning year for me. I don't know about you.
Oh,
And I know we talk about it all the time that we're always learning from practitioners and we're learning from patients, but it seemed like I learned a lot more about deviating from my original plan. And maybe it's now the ability of just being able to see the bigger picture or to see different possibilities quicker.
maybe the word I heard when you said that was flexibility.
Yeah. And you've said something about like flexibility of mind. And I think about that because that is very hard for me. I am a list making schedule. I'd love to have it all planned out, and um, patient care just isn't like that, to be honest.
It's a You're a GABA girl, and
I,
I'm zero, almost no
and maybe
whatsoever.
that's what makes us like a good yin and yang for each other.
Exactly.
Yeah.
I really have to be around GABA people or my life is complete chaos. So your opening question, uh, this is what I want to talk about. That is what gets on the tracks. And
Right.
then I me and my serotonin derail the train.
And it's good for me, right? Because every episode it shows me like we don't have to stick to the script. And however, for the folks that are like me that like to have a plan in place, you can still do, right? The way I've structured my business, especially in the last couple of years, is I like to the night before look to see who's coming in the next day. And I like to jot ideas down of what I'd like to try, what's worked, what hasn't. So I have a plan going
Right.
into the treatment. And
I
there's
think
nothing,
that's a good idea.
I agree. I am just getting better at not getting so hung up on the plan. So when the range of motion isn't what I thought it was, if the patient compliance isn't what I thought it was, if for whatever reason we just need to deviate from the plan, I am better at doing so.
Good. That means it was a good year. Any year where you learned something you didn't think you were going to learn,
Right.
that's a good year.
I think so. I have learned that multiple machines is not a luxury, but a necessity.
Oh yeah. It's we had somebody call the office yesterday and ask how many machines we had that we could put on him. That was his deciding factor about whether or not to get on a plane and come from Louisiana to Vancouver was how many machines did I have I could use? And it's the I've used 9 on somebody. But yesterday I used 4 on somebody and she got up off the table and L4, 5, S1, and S2 were not numb anymore. She could feel the floor with her feet. The abdominal adhesions were gone, so she could stand up straight and contract her abdominal muscles and lift her legs. And that was 1, 2, 3, 4. I didn't even run concussion in Vegas, and it was done. It's 4 machines. So it's not how many machines, it's what you do with them.
Right. And sometimes one is enough, and sometimes two is enough, and sometimes three and four, and sometimes more is not necessarily a more effective treatment. And I think that's what people need to practice. people that are listening, non-practitioners that are listening, just because somebody hooks you up to 6 machines doesn't mean that treatment was any better than the practitioner that used 2 machines. It just means on that specific day, you presented with something that maybe wasn't 6 conditions, it was 2 or 6 tissues, or I don't know. I don't know how to explain it properly, but it's just different.
Like what you do with them. The lady yesterday, her L5 was numb. L4 was better than it was the day before. S1 was hypersensitive. S1 was numb. S2 was hypersensitive. So I went from her low back
Like a sensory exam following the nerve.
with the
Pinwheel.
magic pinwheel.
Mm.
And so I did 40 and 81, 40 on 396 with one machine and 81 and 396 from her low back to around her heels and her toes. And it took an hour and 20 minutes, but the sensation was completely normal. Her feet weren't numb anymore. She could feel she said, "Oh, I can feel the floor."
Wow.
And then the other 2 machines were set up on her abdomen to treat the scar tissue in her ovaries and the scar tissue in her ureter and kidneys and stuff. And
It's funny. I want to go back to 40 and 81. So 40 and 396 on one machine and 81 and 396 on another. Somebody
oh,
went, "Well, don't those two just cancel each other out?" And I said, "No, they're almost like this is how I have a lot of different plays in my head that go with the frequencies. So I see those two, the 40 and 396 on one and 40 and or 81 and 396 on the other, more like dueling pianos.
okay.
So yes, 40 and 81 are opposites as far as one turn stepping down and one turn something up, but they don't cancel each other out like a mathematical equation. They're
Yeah.
doing, like I said, to me in my brain, it's like dueling pianos. Like they're
In this particular case, in when a nerve gets so inflamed, because she has disc bulges at L4, 5, and 5S1, when a nerve gets so inflamed that it can't conduct, it gets hypersensitive and then it gets numb. So in order to restore sensation, you have to reduce inflammation. But then because I was tired of reducing inflammation and I wanted to increase secretions in the nerve so that it would feel things and it would have motor function, I did 81. So both were necessary in the nerve to get the nerve to work right.
and that you can do this at the same time with 2 machines as opposed to running one and waiting and then running another one. If you only had one machine, this is doable. It just takes a bit longer in
Mhm.
that.
Exactly. This is good.
Very organically, one of the things I had circled on my notepad for a couple days is herniated discs. And we talk about discs a lot. Treating discs are easy. It can be tricky, but I wanted to just highlight some things because treating a disc isn't just coming into someone's clinic and lying on a table and getting disc frequency for an hour and leaving. There is homework that is involved with treating non-surgical discs, but it is doable. One of the things I want to highlight from my perspective is the muscles surrounding a traumatized disc are going to have an opinion of their idea of what stabilizing the spine looks like. So we never want to put deep manual pressure or over top of a herniated disc, and we have to treat the surrounding musculature with respect. These muscles are splinting for a reason. So taking out the guarding, even though you know it has to be done respectfully. And I think respectfully is probably the best word I can think of. And FSM has been such a it's almost like the control tower. When things, it will never smush things to a dangerous level of instability, in my opinion. It's always been very responsible as far as, especially when your palpation, as it gets so much better with FSM, you can feel when softening is taking place and it's moving in the right direction. But the other thing I want to say is, if you are worried of taking out too much splinting, in my opinion, rock tape, kinesio tape has been very helpful of providing some really good sensory feedback to that muscle. So it can take the hyperness away from the splinting, but still keep tone in place and give that proprioceptive feedback loop that it's not unstable and it's actually very safe.
And the thing to remember is we're not treating the muscle. We're treating why the muscle is tight. So we're not running 40 and 46. We're not treating the muscle. We're treating 124 and 40 with the disc part. So one of the machines I ran on her was back to front running disc repair. So the reason her nerves were numb was this disc bulge at L5S1. So I ran torn and broken, or basically the protocol disc repair, which is torn and broken in 40 with the
Repair and
disc.
heal.
Yeah, repair and heal. I really torn and broken because that's what's wrong.
Yes.
What is wrong? It's inflamed. What is wrong is not it's repaired and healed. What is wrong is it's torn and broken. So you can look at it either way. But
For sure.
anyway, I
Yeah.
treated the disc, and that made the muscles relax because you're treating why the muscles are tight.
It's just like treating muscle guarding for any reason. Like, muscles don't get tight from outer space, they're getting tight to protect it. So whether there's like tearing, and yes, it's tearing, it's so 124, so tearing in a meniscus or a labrum, and so the
Mhm.
muscles went to protect that. We see that happening in the shoulder all the time.
Yeah.
Thickness tears, we get a lot of muscle hyperactivity to try to stabilize, and the more movable the joint, the more the muscles are going to respond in that manner to try to protect it. To your point, the muscles in the back are, you're not treating the muscles. Yes, the muscles are tight, but your intent is to not treat an inflamed muscle. The muscle, again, it's what's on A, what's on B, but the big question is, how did we get here? Why is this tight? Why is this restricted? Why is this,
What's wrong?
what's wrong?
Yeah. What's wrong is she's got a disc bulge, and that results in numb nerves and tight muscles.
Right.
And the other thing was she couldn't lift her thigh. She couldn't lift her thigh because she couldn't contract her psoas. She couldn't contract her psoas because she had her colon removed when she was 13. And so there's all this scar tissue and adhesions in her abdomen gluing her ureter to her psoas. So she hasn't been able to use her psoas properly. It's just been spastic for, I think she's in her 40s or 50s.
Right.
So she hasn't been able to use it. And it's been so tight that it basically ground her hip joint, her hip into the joint. So the next thing on her to-do list is hip replacement. So there you go.
I want to back up for a second. When we're talking about low back pain, and we'll just do nondescript low back pain for a second, I think we're really good at talking about, okay, what are the back muscles doing? What are the glutes doing? What's happening in the abdomen, right? We look at these three places. And then from a strength perspective, we're giving corrective exercise for the core, turn on the glutes, stabilize the back. But one thing that I think is missed is that those groups, the abdomen, the low back muscles, and the glutes, need to work together in order to have a functional life. And a lot of times the back will turn on, but not the glutes. And then the abs will turn on and not the low back. And that's where the wipe and load research came from, was how do
Mhm.
we get this swimmer who needs to stay in a horizontal plane, who's all of a sudden had that back trauma and now his abs can't fire with his back and he's like this in the water instead of straight. So I like to use the term a polyamorous codependent relationship.
That sounds wrong.
Wrong,
Sounds
but
Kevin
right.
says it sounds dirty.
Polyamorous. The three of them love each other. Those three groups love each other. They work together. And
Yeah,
but they're all dependent on each other. And part of when one muscle group is activated and another muscle group is deactivated goes right back to the perception of, is this safe? It doesn't matter what kind of manual therapy you do, what kind of grade adjustment you do, if it is not perceived as safe to move, you're never going to get that patterning.
fair enough. And you have to think in terms of muscle couples,
Yeah,
right? In order to be balanced, they have to fire in the right amount at the right time. So if these are really tight, like these can't contract, or you have to find out why they're out of balance. Let's put it that way.
for
Yeah.
sure. And it's asking the right questions. And so, to your point, like you were talking about that patient who some people might just write off as, oh, weak hip flexors. And that's a term that we're throwing around all the time right now, are these stretch weaknesses and these tight weaknesses. And I do love when people simplify patterns because it gives us something quickly to look at. But when it's oversimplified, it really bothers me. So, yes, people are sitting now more than we ever have. So, yes, our hip flexors are chronically shortened because we're sitting, but that's not in what, if you had just wrote that off in this case, you would miss everything that patient had about her colon and the scarring. Like you wouldn't think about treating that, or you, without FSM, I guess you wouldn't have a tool to do that.
Exactly. That's part of the challenge that everybody else has.
Yeah.
It's I've as far as I concerned, just because we're sitting and the psoas is short all the time doesn't mean it's weak.
No.
Every single core, when we do the supine lumbar practicum, absolutely everybody with a tight psoas or a pain-producing psoas, trigger points in their psoas, 100% of them, it's scarring in the ureter. It's never the psoas muscle. It's
Right.
one of the strongest muscles in the body. It is one of my GPs told me it's the only muscle that shows up on X-ray.
Hmm.
You take an X-ray of the abdomen and there's the psoas muscle.
Yeah.
Okay, it may not be the only muscle that shows up on X-ray, but it shows up on X-ray.
Yeah.
It's got multiple innervations.
Yeah.
So it's an important postural stabilizer. It's never weak. It's
No.
short, but
No.
the times
Oh,
when it doesn't elongate, when it stays
yeah.
short,
Yeah.
every single time it's been scarring in the ureter.
Right.
There's never a time when that's not the problem.
I just think it's really funny that we think we can treat it, right? Like it attaches onto the spine, and here we are trying to wiggle our way down. And maybe when your intent was to release it indirectly because you are applying such deep pressure to everything that is on top in the abdominal cavity, laying on top of the psoas. And now when you just think about, I always think about FSM helps us minimize the collateral damage, right? So whether we're treating a deep muscle or we're treating a deep tissue in the viscera, you have to be, you again, I'm going back to the word respect. You have to be respectful of everything that's on top of it. And maybe before you just think organs, who cares, because you can't treat it. And I always joke that I'll have netters open and I try to explain, I'll say, oh, I'm just showing you what's all on top of your psoas. It's for me to remember, okay, colon, ovary, ureter, what else is on top? What else could be scarred? What else could be affected by it? And that goes back to your patient history, right? So maybe before you would just skim through all the surgeries that they have. And now you're thinking, okay, gallbladder. Okay, could there be scarring where the gallbladder was? Why did the gallbladder have to come out? It just really helps. It helps you when you are respectful of the tissues and the layers of tissues. It helps you to ask the question why
Yeah.
or how.
And th- the other thing is just mileage. It's in the supine lumbar practicum, let's say 15 years ago when we started doing the supine lumbar practicum, I didn't have the firm conviction that the only thing that's ever wrong with the psoas is adhesions in the ureter. 15 years ago, I did not have that belief.
Right.
But after doing practicums for 15 years, 8 times a year, it's the only thing that's ever wrong with the psoas is scarring the ureter. And then you go to the top and you do scarring the kidneys, sclerosis in the fat pad, follow it down, do scarring in the bladder, and you're done. And after doing that 8 times 10, let's say 80 times, so 800 times a year. Let's just pick that as a number, maybe 600 times a year for small classes for 15 years. That's, let's say, 6,000 times just in classes. That doesn't count the patients.
Right.
So 6,000 times, it's always scarring in the ureter. That's what's wrong with the psoas until proven otherwise.
Mm.
That's just the way it works. And then you can work your way around to the other things that are scarred down, the small intestine, scarring in the vagus nerve for somebody that's had colon surgery. There's all the bleeding in the abdomen, so you have scarring in the vagus. And it's because we have the tool that lets us address what's wrong in specific tissues, it lets us or makes us think about it in a different way.
And thank goodness for that.
Amen. It's true story.
And I do sympathize or empathize with the students that you see them so excited at the beginning of class. And then there's a part in the class where they start to look overwhelmed and horrified because of all the windows in their browser that start opening, right?
Yes.
What do you mean it's not the muscle? I just treat muscles. What do you mean it's not the muscle? If it was a muscle, you would only need 4 frequencies and then you could leave after an hour of class.
Yeah. And then there's that one slide that says, even though you're treating scarring in the ureter or the frequencies for scarring in the ureter, you're only treating the psoas.
Yes.
What do you mean? There's what frequencies you use, and then what you can say in your chart notes.
Yeah.
In your chart notes, you can only say that 13 and 60 takes away the pain and tightness and trigger points in the psoas.
Right.
What's 13 and 60 for? It's for taking away trigger points in the psoas. Yeah, but what's 13 and 60 mean? It means the trigger points in the psoas and the pain in the psoas goes away. Okay. On the one hand, you have to think of the frequencies. On the other hand, you can't make any claims. So that's the part where it gets really painful, I think. And then Kate Adams just said, because she's the one that actually came up with scarring in the ureter. She's the one that did that. Oh, Jennifer Washington said, is the vagus safe?
There is a question above that. So let's just jump to that actually right above. So she says, I have a client coming in for tinnitus. Or tinnitus, however, if you're Canadian or American. It started when she was 6 months pregnant and Started throwing up every day until she gave birth to a 9-pound baby. She also has vasovagal syncope. I'm waiting for her intake form, but no, she had a concussion 3 weeks ago. CT scan was good. Is Vegas safe? Any other suggestions would be great.
It's vasovagal. So, number one, uh, if you're pregnant and you're throwing up every day, you can't phosphorylate B6. So the nausea and vomiting of pregnancy is problems with making the active form of B6. So that's just a little side note. Vasovagal, so what you're saying is she's fainting. So syncope is she's fainting. And there are a number of things that can cause fainting. It doesn't have to be the vagus. Low blood pressure would do it. Has she only been fainting sick since her concussion? Or was she fainting before the concussion? So was fainting what caused her concussion, or did the concussion cause fainting? That's the thing. And I would say treating the vagus is always safe. It has to be working right. I would. And that I would also ask, which caused what? Does the concussion because she fainted, or did she start fainting after her concussion? So there's that, right?
Yeah, so let me just so she has tinnitus. Started when she was 6 months pregnant. Started throwing up every day until she gave birth. So it's been a few months at least since she had the baby, right? Because
Sounds
or
right.
I don't know. Maybe we can get more information from Jennifer. So is Vegas safe? Yeah, let's troubleshoot this for a second. Why wouldn't it be safe?
I can't imagine.
Okay.
So the baby's 9 months old.
Okay. 9 months.
And so
She had a concussion 3 weeks ago, but she hasn't been
okay,
pregnant for 9 months.
so that means, but when did she start? So did fainting cause the concussion? It sounds that way, right?
She also has vasovagal syncope.
Has she fainted more than once? I would still say that treating the vagus is a good idea. I can't think of anything that treating the vagus doesn't help. So maybe I'm wrong,
Said
but
she never fainted.
you don't faint because your vagus isn't working. You don't faint because your vagus is working.
Right.
Yeah,
Okay.
because your heart rate can go up, and so if the vagus is not working, your heart rate can go up, and then your brain decides that you need to be horizontal because it can't pump enough blood to your brain to keep you vertical. So you have to lay down now, so it faints.
Right. So the comment was she said she never fainted.
Then
I
what
wonder
is,
what the vasovagal syncope symptoms were then.
yeah, syncope means she fainted.
Right. That's how I understood it. Maybe she just had fainting like symptoms.
Well, syncope means you
That's
fainted.
right. But
So I would say, yes, you could treat the vagus. Yeah,
and would
and
you just do 81, 109?
sure, I would.
Yeah.
But she said she never fainted. But then what does vasovagal syncope look like? And then tinnitus, if somebody has tinnitus that is persistent, then they need a hearing test, because tinnitus is phantom limb pain for the ears.
Yes. I love that phrase.
Yeah. Isn't that great? That is Sue Doucette. She's an audiologist at Good Sam.
Yeah.
Yeah, it's it's phantom limb pain for your ears. Means you can't hear.
Yes. That is fantastic. Okay. So hopefully you have some things to try when your patient comes in. Would you add anything else for her to test and or look for?
Check the patient's
Mm-hmm.
heart rate is 84, then the vagus isn't working. So you can use that as an indicator as to, you can use her heart rate as an indicator to see what the vagus is doing. She just told me she has the condition. I need to know what to ask. If she says she never fainted, then you have to ask her what she means by syncope.
Mm-hmm.
And who told her that's what she had if she's never fainted? What is that? Because vasovagal syncope is fainting because somebody thinks your vagus isn't working.
Right.
As far as I know, that's
Yeah.
sounds like somebody's confused.
Yeah. And you know what? Like sometimes patients do come in with conditions that somebody labeled them with for no good reason other than they were also confused and just gave this person a label and sent them out the door. And we see this with frozen shoulder. We see this with hip impingement syndrome. We see this with piriformis syndrome.
I
We
love
see
that.
it with so many syndromes,
Mhm,
right? And people become attached to, we even see that actually with fibromyalgia,
mhm.
right? I had somebody who just had pain with one shoulder underneath one shoulder blade and was like, I have fibromyalgia,
Of the right shoulder.
one spot, zero other symptoms.
No, what you have is a lazy doctor.
Lazy, we can put that in the syndrome because and I'm not trying to oversimplify anything or minimize anybody's diagnoses by any stretch, but I'm just saying that there are a lot of times where you have to take a previous diagnosis, but still do your own exam and still connect your own dots. So there's a question there too, with like you said, who told her that she had this
Why?
and why?
If you've never fainted, then the other thing is there's so much power that a patient has with just Google.
Yeah,
Just bring up a search engine and you can bring up syncope and find out what it is. And you bring up syncope and it'll say it's fainting. Well,
right.
I never fainted. So what is this thing that I have?
Yes. We were talking about this when we had Charlie Weingroff on a while ago, how you have to take their old diagnoses or their previous diagnoses, but you have to also look at imaging that they brought in and the relevancy to their symptoms and put those three bubbles together with your own exam and come up with your own findings, because just because somebody was diagnosed with something 4 years ago doesn't mean A, it's healed, or B, it's gotten worse, or
Yeah, true that. We need to answer Leaf's question because
okay.
he's not seeing, oh, he
Okay.
says, I'm not seeing some submissions on either the chat or the question.
Well,
So
maybe
Leaf's
nobody's
question, say again.
asking questions.
Uh, There's one, Leaf has a question. You referred
Yes.
to warming up the hands
Mm,
last week, but I can't recall the numbers. What are they? Raynaud's was the issue, and it was 81 and 62. That was Dave Burke that did that one, and he did it with an eye care without even the magnetic pad. They had
wow.
the eye care app on their phone,
Right.
and everybody knows you can't use the eye care in your office. But Dave had his phone in his pocket, and this patient had Raynaud, so his hand was white, and he put 81 and 62 on the phone with the volume down. The patient held the phone, and they all just watched his hands turn pink instead of white. And then his wife had Raynaud's too, so they put 81 and 62, and her hands turned pink. That was pretty cool. So
That's amazing. I have yet to try it.
when we talk about long COVID. When Christy Hughes lectures at the Symposium, she's going to be talking about the endothelium in the arteries and the capillaries. And she's actually talking about the endothelial glycocalyx. And even after hearing her lecture in Las Vegas, I still have, I don't know what that is exactly.
Yeah, I was just gonna say, you lost me at endothelial.
Yeah. So when she makes her slides for us, the first part of her presentation is going to be explaining what the endothelial glycocalyx is. But long COVID, one of the consequences of COVID and actually the vaccine for COVID is that this lining of the arteries gets disrupted and rough. And instead of having a smooth place for the laminar flow of blood, you've got this rough, uneven surface. But part of it's Christy is lecturing Saturday and Jerry Pollack is lecturing Sunday, I think. And if you think about what he shows as that laminar flow, the fourth phase of water, the laminar flow along the inside of the blood vessel or a tube, if the laminar flow is disrupted by an uneven, rough surface, then you have a problem, right?
Right.
So it's that that's what she's going to be talking about. And 80 repair or torn or broken, and inflammation and increased secretions, because the lining of the blood vessel, arteries and capillaries, constantly secretes this smooth, almost like seaweed, how it's
Mhm.
sort of filmy,
Mhm.
this smooth lining on the inside of the arteries. And that's the glycocalyx. It's smooth.
Mm.
And it is a secretion on the inside of the arteries and probably the veins as well. Because we had that case report where the physical therapist, it was Jesse Tierney, ran for a deep vein thrombus
Right.
in the better part of the lower leg. She ran torn and broken and vitality. That was it. Torn and broken and vitality in the vein. And this huge blood clot and a D dimer of 5 was gone the next day. And that is impossible. But it also suggests that the normal function of the vein means that the vein secretes something that keeps its functioning correctly.
Yeah.
Because if you think about this femoral or sciatic artery, vein, nerve complex that come down the back of your leg, you're sitting on it all the time.
Yeah.
Why don't you have blood clots in your legs all the time? It's because of something that the veins and the arteries are secreting that keeps them healthy. And we have apparently have the ability to influence that.
Talk to me about this bear.
Let me get the bow out of the way. It says,
I
I like
love
to use them.
That is so cute.
It seems appropriate when we're talking about this thing that FSM can do that nobody else can do. I love FSM. So it is in if you go to frequencyspecific.com, it's in
Products and then merch.
products. So there's a tab on the frequency specific website, frequencyspecific.com. There'll be a little tab that says products. And then there's something called merch, which is short for merchandise. and the bear, plus t-shirts and stuff like that. But the bear is, so I'm going to keep the bear on my desk. And when we talk about doing something like fixing somebody's sciatica so that their feet aren't numb, and we're the only ones that can do that. So just put that up.
Bear. And what a gift that little bear is, and all the hope. I want to bring the train that went all over the place just now back to some questions for you for our like year-end roundup.
Oh, wrap up.
Not a, no, just I like summaries. I like conclusions. I like reflecting on, like I said, what I've learned. Has there been a frequency that has been new to you or that has stolen the spotlight a little bit? Do you know, like every year we have one, right? Like a couple years ago it was like torn and broken is time dependent. There always seems to be something that we chat about. Do you have one that you can think of?
This year, the surprise for me, because how long have I said there's nothing we can do for vestibular injuries?
Yeah. Just kidding.
40 and 44 is the one that's like, really? It works?
So
Seriously?
40 is inflammation or quiet the activity of, and 44 is the ear.
Inner ear, the inner ear, the vestibular system.
Yeah.
As far as I can tell, it doesn't do anything for tinnitus,
Right.
but it makes disequilibrium go away at least temporarily.
Yeah.
So if somebody has a vestibular injury and you're treating their neck and their neck doesn't go smush,
Mhm.
their muscles stay hard, and they still have this sense of disequilibrium. You put 40 and 44 at the beginning of the supine cervical practicum, or you set up one machine that only does 40 and 44 for the whole time they're treating their neck, the neck muscles just go smush, because one of the reasons that the neck muscles are tight is that the brain needs to know where it is in space. So it tightens the neck muscles and they stay tight.
Right.
You can do everything you want to the neck and it works. But
Right.
when you add 40 and 44, it makes you realize that vestibular injuries create neck
Yeah.
pain, because tight neck compresses the joints and the discs. And then you find somebody that has had one minor fender bender and terrible looking x-rays and multiple disc bulges that don't make any sense. They're mild, but they're everywhere. And it's like you run 40 and 44, the neck muscles relax, and that makes it make sense. Because if everything is under compression, then the joints are going to degenerate and the discs are going to get little teeny non-active bulges, and there hasn't been any trauma. It just,
Don't you also notice a correlation between vestibular, cervical, and then TMJ dysfunction is soon to follow? And that's secondary, right? I want to say, what was the statistic? Like 94%, 93% of all TMJ dysfunction is muscle based, right? Like the joint just doesn't deteriorate, the disc just doesn't deteriorate. It's not like an extremity. So if it's coming from the superior slip of the lateral pterygoid, that is a mechanical problem from mechanics happening in the neck, and the mechanics in the neck are happening from the vestibular injury.
unless the dysfunction in the muscles is coming from
An infection.
a ligament strain,
Yeah,
or they had braces. So I've
sure.
had TMJ ever since I was 19. What happened when you were 19? got my braces taken off. And so there are those wires and headgear pulling on the jaw, on the teeth ligaments, and it creates damage to the ligaments. You treat torn and broken in the ligaments, and all the muscles relax. It's like when partial thickness tendon tears cause the muscles to be tight. So if there's no reason, for example, when did you have TMJ? When I was 22. What happened when you were 22? They took my wisdom teeth out. Okay. Do you look at the mechanics of getting wisdom teeth removed? They block your jaw open for up to an hour, creating a tendinopathy in the pterygoid. And then the pterygoid muscle becomes tight because the tendon is injured. And that creates the popping in the disc. And that creates the joint dysfunction. And that creates the tightness in the temporalis and the masseter. But it all started because they jammed the jaw open for an hour.
Right.
As
And
they
that's
were
1/4. That's torn and broken, right? So
Right.
whether it's from a prolonged dental procedure or just the changes that happen with the ligaments as teeth are moving and the jaw is adjusting, whether it's from trauma, slip and fall, a punch, motor vehicle accident, it all of it has to start with 124. It's torn and broken. And I do want to say my deep dive into that TMJ webinar over COVID when we're looking at the cadavers and what is behind the disc, that retrodiscal tissue, which is adipose, but it bleeds easy. And as they're lecturing about this, retrodiscal tissue is highly innervated and it bleeds easy. I'm just seeing 18 and scarring in the adipose and like places that you would never think about treating in the jaw, but because of that pterygoid pulling on it, everything just continues to tear. And nothing will respond. It will respond, but it won't stay. Nothing will hold until you treat the driver, is what we always say, the cause.
Yeah, exactly.
Couple questions that came up about accessing past webinars. So again, that's on the website. You can look at us on YouTube. You could watch old podcasts on YouTube or listen to us on Spotify or anywhere you listen to your podcasts. Just type in frequency specific microcurrent podcast and we will pop up on different platforms. But the webinars are only on the website. So frequencyspecificcom/webinar. And you can hear the Vegas webinar I listen to all the time. I always take home something new. And the Ehlers-Danlos webinar is fantastic. So even if you have patients, I'll play little clips from your talk on that because it puts so much together for people who need to hear their symptoms and their world buttoned up in a package that
And a context too.
absolutely.
My favorite ones are the Vegas, Ehlers-Danlos, and mold. And then before I did topic webinars, I did 5 years worth of practitioner webinars. So there's one that's called Put It Together. And there's 3 different cases. And there's one that I can't remember all the names of them, but they were, all of them, I think, are like 3 case reports that are unusual cases that taught me how to think about things. Right. So those are pretty fun, but you're right. The Vegas, the Ehlers-Danlos and the mold are, I'd say, the biggies.
Yeah, that we know these things, but hearing it again and again, it's like going to the core multiple times. We're not slow learners, but you just hear things differently. And I guess you're just ready to hear more information when you're ready to hear more information.
It's why I read Roger Billica's Neurotransmitters. What did he call it? Molecules of Behavior.
Yeah.
It's I watch that probably 4 times a year. And once you see it, you can't ever unsee it. It's the truth with all of them. I
Right.
suppose we should do one on vestibular injuries. That's on my list.
Yeah.
And then Kevin has a list of things that he wants us to do webinars on some quiet Wednesday when we're not doing a podcast. So that's a possibility. And
Or we'll start early or stay late on a podcast day.
if you're working on the endothelial glycocalyx, what frequencies do you think would work? Torn and broken, 40, 81, and 49. Reduce inflammation, because inflammation is how it got broken in the first place. I guess you could, if it was after COVID, I guess you could run this 6 COVID frequencies, then reduce inflammation, increase secretions and vitality. That kind of makes sense, doesn't it?
It does. Yeah, it's a great place to start anyways. Seems like you're covering all your bases with.
Yeah.
Interesting. I do have a couple things also that I want to get out before the next 9 minutes evaporates on us.
Okay.
The end of the year sale, I mentioned it briefly at the end of the podcast last week, but it is a great sale. It is a great time to, as you mentioned, get some extra write-offs for your accountant. But I want to, I get questions all the time about the magnetic converter. And
Right.
I believe, or maybe it wasn't you, but it was once said that it's not great at treating nerve pain. However, you successfully treat your own nerve pain with it, correct?
Yeah, I say that it's not that great at treating the cord of the nerve, but if I wake up in the middle of the night, my hand is numb and painful, I'll put one puck up my neck and one puck in my hand, and I've got 40 and 396 on my custom care, but it's alternating because the magnetic converter can't do polarized. It has to do alternating. And I punch a button, put the puck in my hand. In 5 minutes, the pain is gone. I go back to sleep. And that 40 and 396 runs for about 60 minutes. So it works. I have to confess that I have a converter in the office, but I don't use it. I use the
Cows.
towels and clips because there's just a limit to the weirdness factor. It's weird enough to use frequencies you can't hear and current you can't feel without using something with blinky lights in the office. So there's only a certain amount of woo-woo I'm willing to expose my patients to. I need them to think that something real is happening.
And you're right. I think a lot of patients are so used to having very invasive treatments. So the deep moist heat from the towels is like the least I can do to give them some sort of sensory
Yes.
feedback until
Exactly.
they know what to expect and that results take place. And
For the practitioners, the best reason to buy a magnetic converter is to treat yourself at home.
yes,
That's most important is I can't take the time in the daytime to treat myself, but I get in bed at night and I have a nighttime program that starts with concussion in vagus, goes to insulin resistance, goes to vascular health, goes to heart health, and the thing runs 4 hours. I'm not going to treat myself for 4 hours in the daytime. With a magnetic converter, I just set it up, punch a button, roll over and go to sleep.
you're lying there anyways.
Exactly. And then there's this really cool feature in the new software where you can click a button and copy a protocol and then paste it on another protocol and then copy another one and paste it on that. And so that's how you end up with one protocol that's
Hours.
long.
Right. As opposed to having to get up in an hour and change it. Like, who wants to do that? Because then you're not sleeping and you're going to feel like garbage the next day because you're not sleeping. And then you're going to blame it on FSM when all you needed was a good night's sleep. So yes, you can batch those programs together to make a super sleep protocol is what I like to call them.
Yeah.
And all those everything I believe is on sale right now, like the magnetic converter, the custom care, the precision care. Correct me if I'm wrong, Kevin, but I believe it's all on sale.
And the early bird special for the advanced and symposium ends on December 31st. And I'm excited about this year. It's the first time ever that the whole afternoon and part of the morning at the symposium, I had to take our 90-minute plenary speakers and ask them to shorten to 60 minutes so we could fit in all the case reports. So that's
The
exciting.
case reports are so exciting because the lectures are exciting with the topics as well, but the case reports help put everything together for you, because every case report you have a client or a patient that is very similar or similar enough that it sparks those ideas. Or it'll give you the confidence of, hey, I have somebody similar and that's what I do. And it's just so great to see that's our those are our research models. It's to see that live and their thought process. I think true learning really happens in those examples.
When we find out things we didn't know we could treat.
Right.
And you find out it's reproducible. And to tell you, we have a practitioner coming from India that spent a month and a half trying to get a visa to come here. We have a practitioner presenting a case report from Poland, from Rome. It's just mind-boggling, the kind of people and the skill sets and the different degrees, naturopaths, osteopaths, physical therapists.
Amazing that so many different professions can come together, unite in one room, brainstorm, share ideas, get inspired, and then get on a plane and go home and do it all over again.
Yep. And besides, the food's great.
And the food's great, and Arizona in March is great. It's all just, it's great. Is Jay Shaw coming?
Oh, and Jay Shaw's coming. He is. He loves us. So he literally asked me, can I come? Can I come this year?
You're never going to say no to Jay Shaw.
And he is 190-minute slot. It's tough cramming Jay Shaw into 90 minutes, but he said, I can do that. So there we go. So we have Jay Shaw and Jerry Pollack and Juliana Mortensen and Christy Hughes and Eduardo and we have the Feinstein data on the vagus nerve. It's been patented. Yeah, so we can actually talk about it. I don't have to keep quiet.
Yeah.
For the last 2 years, that's how long it took them to get this data. So
Amazing.
yeah, Jennifer Ernst is coming. She's the CEO of the company that's creating the device. Yeah, it's going to be fun.
So many great things. So
it's going to be live streamed. So if you absolutely can't come, it will be filmed and live streamed thanks to David Eakes.
Yes. The unfortunate part of live stream is that you can't meet up with your friends in the hallway and geek out over numbers and all the tables that we have for the different like themes, and those are always great. So you could sit down with your fellow
geeks.
I was gonna say a different word, but geeks is what I wanted to say also. And be proud of it and just be a nerd and geek out and talk in numbers. And
Candace Elliott called them special interest tables.
Yes, that perfect. That is exactly what it is.
Yay.
So you miss out on that, but live stream is a great option. if you absolutely can't travel. So
Yeah.
get your registration in, buy your devices now, and then you're all set for the new year.
And don't forget to make hotel reservations.
Yes. Because you don't want
Um,
to leave. You want to stay in that complex because everything is there. You do such a great job of feeding everybody, but there's great restaurants and things to walk around and little shops. So you don't even need a car when you go there, which is what I love.
and our overflow hotel there's one across the street and one down the block. If our block is full, then you still have some place to stay.
Yes.
Oh.
That is it.
Your timer just went off, I can tell.
It did. It just beeped. This went by really fast, but I'm grateful for our little roundup.
Yeah,
Our
it's
little
been quite a
celebration.
year, hasn't it? It's
They're
amazing.
always amazing years, but I think there's just always so much to reflect on, look back on, and what did you learn and how did you grow? And then you get to move forward with the next year with all those things. And a
You
teddy
got-
bear to hug.
Are we doing a podcast on New Year's Day?
Oh, we can.
I don't think so.
Yeah,
I think-
I
Do you
think
want
we
to come to work?
Then it's going to be a couple of weeks before we are on.
okay.
Do you want to come to work on New Year's Day?
I'm just checking. I'll do whatever.
So this is what we do. We'll sign off now for a fabulous 2024 and even greater 2025.
Yep.
Thank
And Merry Christmas and Happy New Year and do good things.
Yeah, and just enjoy stuff. So thank you to everybody for coming and letting us do this week by week.
Yay. I love
All
it.
right.
Bye.
Well, we'll see you next year.
See you next year.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.